And good evening and welcome everyone. I'm John Sandville. I'm the superintendent here at the Unionville Chadds Ford School District, and I am happy to host virtually. And really, I have to thank our Director of Technology, Mr. Webb, for making the magic happen this evening and his team. So, Mr. Webb, thank you. And this evening, for making it all happen. And I'd also like to welcome the fine folks at Great Valley and thanks to Dr. Gaffredo and Jen Blake for their partnership in organizing this evening's program. And also a shout out to our communications director, Chris Afazio, who was instrumental in putting this evening's event together. Momentarily, we're going to turn this over to Dr. Matone and Dr. Rubin, who are really our guests of honor, and we're thrilled to have you both, and really looking forward to what you have to share. But before I do that, I just want to thank all of you, the staffs at Great Valley and Unionville Chadds Ford, on behalf of Dr. Gaffredo and myself. Uh, we get it. We understand what we are asking of all of you. This is the task is daunting, right? We are asking you to educate students virtually. We're asking you to transition to a hybrid model, all the while during a pandemic, and that is no easy feat. And we know that you are putting in tremendous hours. You are taking care of your own children who are also in hybrid models. We know there's a lot of competing factors here, and we appreciate, Dan and I have had many conversations over the last few months, going back to his assistant superintendent days, which he may want to go back to, and to today. And we get what you're doing, and we thank you for it. My hope for this evening is that we're going to venture forward afterwards with a little more understanding from a COVID-19 perspective, and what it is that we should expect when we start to see children in person. And that knowledge gives us power, right? And so I think this evening will be helpful in that regard. And if I can just take a moment. I know the Unionville folks know that I like a good quote, and that I like Winston Churchill. So I'll leave you with this one. If you're going through hell, keep going. And with that, I'm going to turn this over to Jen Blake, who is going to be our moderator this evening, and let her do a proper introduction of Dr. Matone and Dr. Rubin. So Jen, it's all yours.
Thanks, Dr. Sandville. As Dr. Sandville mentioned, we are pleased to have with us tonight two individuals who will help us navigate the whole issue of COVID-19 and school opening. Dr. David Rubin is the Director of PolicyLab at Children's Hospital of Philadelphia and a professor of pediatrics at the Perelman School of Medicine at the University of Pennsylvania. Dr. Rubin is one of the lead investigators on PolicyLab's COVID-19 forecasting model, which tracks coronavirus transmission and test positivity rates across all U.S. counties and projects case counts for 817 counties with active outbreaks. Dr. Meredith Matone is the Scientific Director of PolicyLab at Children's Hospital of Philadelphia. In this role, Dr. Matone is responsible for overseeing PolicyLab's research pipeline and recruitment, research-related planning for PolicyLab's portfolios, and center-wide research strategy and supports provided to PolicyLab researchers. Both Drs. Rubin and Matone provide guidance to state and local health departments, as well as to school districts, and have been featured in the news regarding the safety associated with bringing students and staff back to school. We'll begin tonight with the doctors, who will provide some general information about COVID-19. From there, we will welcome questions from our participants via the Q&A feature in this Zoom. Please note that this presentation is really designed to provide health information related to COVID-19 and school reopening. Questions not answered by the doctors, or ones that relate specifically to one of the participating school districts, will be recorded, and the individual districts will follow up tonight's event with a more direct FAQ type communication to staff. All that said, Drs. Rubin and Matone, welcome and thank you. Let's begin with you.
Well, thanks for having us. Actually, we found over the last few weeks as a team over at Children's Hospital of Philadelphia that the most important conversations we needed to be having were with parents in the community, but particularly with our teachers and staff throughout the greater Philadelphia region to try to really give you an honest appraisal about what you are facing as you go back and what we're learning. This is obviously a moving situation, and the epidemic is changing week to week in our own area, and it creates a lot of anxiety. I just want to identify and empathize with the amount of anxiety this has created for everyone, but particularly for you all as you get prepared to try to return to school now and trying to figure out, well, how well is this going to go? And I hope that in our comments tonight that Dr. Matone and I are going to help you kind of really understand what the risk is. We began this modeling effort back in March and April because we knew that state models and even national and certainly national models were not going to help your school districts figure out, well, what was the risk in my own backyard. And we had a lot of experience looking at the variation in services, for example, for families throughout the state of Pennsylvania. And so we began this model with our eyes on September, and how we were going to assist schools in the challenging decisions around reopening. And that's led now to a model that every week we're forecasting the direction of the epidemic in over 800 counties. We are now up in all 67 counties in the Commonwealth of Pennsylvania with a separate dashboard that allows every parent, every staff member to follow case incidents, trends in weekly case incidents, trends in test positivity, which are two of the metrics that a lot of districts are following as they make the decisions, and not just to continue their incremental reopenings, but also when to potentially revert to distance learning, which I suspect that we're going to have to make some of those challenging decisions, and we're going to have to dial it up and dial it down. I will say that a lot of there was a lot of discussion about the PolicyLab guidance that our team put out, and Dr. Matone is going to talk about the essential elements of a multi-layered public health approach to protecting against transmission within the school during the school day. But I'm going to talk to you a little bit about our decision making, which is, many folks saw our document earlier in August where we first said, that if you're just going to speed right into a full reopening, you better be at case incidence that looks like what Europe was back when they opened in the spring. And that was pretty much unachievable in most of the country at the end of the summer. We saw a very difficult summer with a lot of transmission. It was principally among younger individuals. And as we approached the end of August, we were starting to kind of come into the terrain for our upper threshold, which was about 35 cases per 100,000 per week with declining test positivity. And actually, much of the Philadelphia region was moving in that direction, although things started to get a little worse towards Labor Day. We got college reopenings going on. We knew vacationers were returning. And we made a challenging decision to delay our recommendation to reopen schools, particularly as we awaited the impacts of Labor Day, which were substantial in some areas of the country. They were present in the Philadelphia area, but they subsided fairly quickly by the middle of September, putting us in what has been what I call our window of opportunity, where you have the lowest case incidence you're probably going to see in the last couple of weeks between now and next spring, or at least until the vaccine starts arriving and starts to penetrate into some of the disease transmission. That said, I think what we had a couple other as we now kind of we moved into September. There were a couple other things that were, as we put together our public health approach, we sort of saw a recipe, which was basically if we could get some declining incidents, that could establish a safer zone to kind of stand up these protocols that Dr. Matone is going to talk about. But we were also aided by new data from the children's hospitals that came out late in August. It wasn't featured in the media. It came as a research letter to one of the medical journals that looked at the pre-procedural COVID screening rates among children presenting to the children's hospitals, including in Philadelphia, in terms of what the positivity rate was for those kids who were not sick. They were just showing up for elective surgery. And that was done throughout the country. And it allows us now to take a look at what case incidence is in an area and understand what that means for a school of, let's say, 1,000 kids on day one. At the levels we've been in, let's say in the Delaware County area or the Chester County area, 40, 50 cases per 100,000 per week. That actually now has allowed us, based on these data, plus other data coming in from schools that have been testing, particularly our private schools, to estimate that a school of 1,000 might have 5 children and maybe a staff member or 2 who show up positive in week 1. And you should expect that you're going to have cases every week as long as that incidence remains. Then the question becomes, at that level of incidence where there are 5 kids who were circulating, might be asymptomatic, but might be COVID positive, with people wearing masks and doing all the things that Dr. Matone is talking about, what is the likelihood that, that your protocol with its multiple layers can safely assure that you're not going to have outbreaks originating within the schools? It's also allowed us to say, well, is the difference between 50 and 70 that substantial? Is 5 or 7 going to change your opinion on how well your protocols can protect against transmission in the school? And it's allowed us to now revisit in terms of what we're moving away from focusing on the absolute threshold now. And in a call with the county health department directors, you have 4 county health departments in the Southeast region, including a terrific Chester County Health Department that serves you, where they are following every single case in schools that have now reopened. There are lots of schools throughout the area have reopened, and they have yet to find a case across these health departments where they have proven transmission within the schools during these reopenings. And some schools are more open than others. In areas in Bucks County, they have full school reopenings in many cases. So that lends us a lot of confidence, even at a time when there's some uncertainty about the directionality of transmission, that schools have a good runway for reopening with protocols that can make you safe as you return to school, and assure that the cases that are coming to school are most likely coming from infections that were acquired outside in the community. And the final note I'll say now is, I remember, and I've talked to other schools about this, I remember back in April or May when the hair salons just reopened. I don't know if those of you remember, there was a hair salon in Missouri in which 2 of the stylists were symptomatic with COVID, and these were adults. And they took care of about 140 clients. Both were wearing masks. Both were in close proximity for a much greater period of time, probably 30, 40 minutes at least, than close contact suggestions would suggest. But in the presence of those masks, none of those 140 people got infected. That type of data is extremely valuable as you reopen schools, and should give you confidence that these protocols that Dr. Matone are going to describe are going to work, because there's many different layers involved. And so with that, I'm going to pass it to Dr. Matone, and she'll talk about sort of what are the essentials of a school health plan.
Sure. Thanks, Dave. So I think just to sort of start off and reiterate a couple of the concepts that Dr. Rubin was talking about, I think, when we think about what makes us for a safe school reopening, really it's not one thing. And we also go in sort of building school plans knowing that there's not going to be 100% fidelity to every intervention. And that's why, from a public health perspective, we build and are suggesting layered approaches that include multiple components, each sort of adding protection, so that when there are sort of breaks to fidelity, then we're still left with several other facets of prevention. And I think foundationally, the relationship between the community case count and the risk in schools is such that we know that children, staff, are members of the community. And so what goes on in the community will be reflected back in the school. And that's just an important concept to think about. And so our goals when we reopen schools are really to acknowledge, as Dr. Rubin has said, that we're not going to keep all of the positive out of school. There's not really a reopening strategy that will allow us to prevent any individual who is positive from being present at school. What our goal is to prevent linked transmission within school, to prevent any cases originating in school, and to create sort of that protective bubble in the school environment that reduces the likelihood that any child or teacher will be infected at school, and also to cultivate a school community that understands and feels accountable to their commitment in their home and community participation to infection control practices that mirror what we're going to be asking at the school environment, right? And so I think that sort of one of the things that we think about when we think about creating the school policies is thinking about how are we communicating with our families as part of the school community to sort of cultivate a shared understanding of the relationship between the activities that happen at home and in the community and the success of the school reopening, and wanting to make sure that everyone in their home life is following the best possible infection control practices, so that when children come to school, they're coming to school with as reduced as possible exposures that are happening in the community. But beyond that, when we think about schools, I think there are a few things that we think about. The first is a sick policy. So how on a daily basis are we monitoring staff and students for symptoms and new exposures? And really, that doesn't necessarily have to be something that occurs on school grounds, but as long as there's a shared understanding and very clear protocol that individuals who are symptomatic or who have suspected exposure are not coming to school, that's a foundational public health intervention. And that's something that should be clear to all staff as well as all families. As part of that is also establishing what at the school level is the relationship of the school in terms of accountability and point of contact to the county health department, who is going to be responsible for communicating back the appropriate protocols every time that an exposure or positive case is reported. And so making sure that those clear lines of communication are open, that everyone knows what those protocols are in terms of who the reporting is going to, who they should expect to hear from, what the time frame they should expect to report any new information is. All of those sort of lines of communication, while it's simple, they're very important and actually very effective when done correctly. The most important thing is in a timely fashion. Everybody needs information to make the appropriate decisions about quarantine and exposures, and establishing those lines of communication are critically important. When we think about interventions for staff and students, we think about masking, as Dr. Rubin mentioned. The longer the pandemic has gone on, the stronger the evidence that has accumulated around masking. We have really, really good data about the efficacy of masking in reducing transmission of virus. And so what we are recommending is that all adults in the building are masked at all times, and that children are masked also, really with very, very limited exclusions for children. We're not seeing a lot of contraindications for child masking. And so we would agree with and support the state's recommendation that children over the age of 2 who are developmentally able to wear a mask, be wearing a mask inside of school, and to the extent possible, even outdoors, if there's going to be close contact. We know a lot of times recesses outdoors, and other sort of physical exertion activities where youth are coming close. Certainly outdoors is a safer environment in terms of virus transmission, but as we're heading into some of this cooler weather, I think the importance of masks, to the extent possible, can't be understated. The second sort of part of that goes hand in hand is distancing. And point that I'd like to make is that we've heard a lot from folks thinking that masking and distancing is an either or. If I've got masking, then I don't need distancing, or if I'm able to be 6 feet apart, then I don't need to consider masking. That's not necessarily how we're thinking about these two strategies. We're thinking about these two strategies in a layered manner, that both are absolutely better. And again, we know in particular in a school environment that we're likely to be in a situation where we're going to have breaks in fidelity. Kids are going to be kids in terms of masking compliance and distancing compliance. To the extent that we have two layers of protection, that's really what we're looking for. And I think, again, the evidence is very strong that neither one alone is a silver bullet, that to the extent possible, as feasible, using both of these strategies is your best bet for protection. I think we also understand, though, that distancing in particular is very challenging in a school environment. We know that classrooms and teacher-class ratios were not necessarily designed for children to be 6 feet apart. That said, we still feel very strongly about the efficacy of this intervention as something that is really grounded in science. And so we know there's been sort of discussion of 3 feet or 6 feet. By and large, we're fairly strong proponents for 6 feet of distancing. I think in circumstances where 6 feet is not feasible, I think those are the circumstances where I'd really be thinking about as strong of mask compliance as possible, and reducing the duration of time that we have individuals sort of congregating less than 6 feet of distance. The last thing that I'll sort of talk about and I know I've talked about these in broad strokes, and happy to answer sort of more specific questions because we understand that the implementation of all these things is very complex and nuanced. But the last thing is around hygiene and disinfection. And I think COVID, like any respiratory virus, it's important to think about enhanced hygiene and disinfection. And so from a hand hygiene perspective, I think what we're recommending is that we use this as an opportunity to increase hand hygiene practices in the school, to increase sort of health education to students, so that best practice in hand hygiene is top of mind for everybody, and that it's incorporated throughout the day. So around meal times, around restroom times, that these are all points in the day to remind and sort of do best practice around hand hygiene, and that the use of hand sanitizer and having that be available, particularly around shared surfaces and entry and exit to classrooms, is beneficial. And then disinfection, I think about sort of how environmental services protocols normally operate in the school. And if it's normally sort of an end of day cleaning, then what we might recommend is sort of a little bit more than baseline. So maybe a midday and an end of day cleaning of restrooms, for example. If you have a classroom that you're going to have a number of different classes cycling through that classroom and using a lot of shared spaces, desks in one particular classroom, then that might be a classroom or a space where you might also want to do a midday wipe down of those surfaces. I don't think that from our perspective, there is not a need to drive yourself crazy over disinfection. It's definitely important, and we would definitely recommend sort of an increase from baseline, but it is not something that needs to be incredibly complex. So with that, maybe I will, it's a lot, so maybe I'll pause and we can go through questions. Like I said, I know that the implementation of this, it's all in the details, sort of what this means and how to interpret it.
Great. We do have a number of questions that are coming in around some common themes. I'm going to do my best to sort of group them and ask the questions accordingly. But the first is, we certainly see a common interest in returning to more in-person instruction for our students, but we want to do that as safely as possible. As we think about bringing kids back, is it acceptable to start thinking now about bringing our youngest learners back into school with less than 6 feet between them, perhaps 3 feet, if the transmission rates are lower for that population? And then the same question for the older population of students. How relevant is that 6 feet distancing?
Well, I'll just say that, obviously you got to make practical decisions in what you're doing, but I'll tell you that of all the interventions that we have, physical distancing is the most effective intervention. I wish I could say the other ones were better, but so if you're going to trade physical distancing, you have to ask yourself in a multi-layered approach, can I boost other things? And we understand we have had this discussion around busing, if you can't do the distancing on the buses, then you got to open the windows, or maybe you have a bus monitor to make sure everyone's keeping their mask on and sitting in their seats. And maybe you're assigning seats on the bus where siblings are sitting together, you're cohorting kids. And this is where we have to be creative in terms of boosting different strategies when you're going to sacrifice on others. You're just sacrificing a lot when you go down from 6 to 3 feet. I also think for the teachers and the staff, I would want to distance them further. If you're less de-densified in the classroom, well, then put some more distance between the teachers and the kids. And in the elementary school, in the early elementary age, you can't entirely do that, right? And so, for those teachers who are going out, because it's a little more hands-on, 6 feet, 15 minutes, right? Particularly for the teachers. Because at the end of the day, people have also asked about, I saw a question came up about the case incidence rising in kids, and what does it mean that more kids are getting infected? In general, it still means not very much. I mean, even in college students, we're not seeing a lot of severe infection in the kids. This is largely about reducing the likelihood of in-school transmission events, so that the kids who are not infected at home don't bring it home to their families. All right. But really, it's principally about protecting you and assuring that you can do your work safely and educate kids this year. And to that degree, you just have to think through these multiple layers. And when you make those pragmatic decisions, recognize the ways in which you can boost your effectiveness or your layers in other ways to mitigate risk. And that's probably the best answer given the practical realities of what many schools are facing.
Okay. We have questions about air quality in indoor spaces. The CDC recently reconfirmed that the virus is transmitted via airborne particles. As we begin to transition back into confined indoor spaces with large groups of students and staff, how can we ensure safe indoor air quality? Could you specifically address recommended minimum air exchanges? And if those can't be achieved with existing HVAC equipment, is there anything we can do?
Well, first of all, I mean, there's been a lot of politicization of what the CDC is actually saying. I mean, I'm not surprised that there are some episodes that have been linked to aerosolization of this virus, right? Which means tiny droplets. But there has been no change in our opinion at the Children's Hospital of Philadelphia that the primary mode of spread of this virus is by large respiratory droplets. And why do we say that? Because the best evidence of what's really happening is what's called the secondary attack rate in households. And that, when you look at other members of a family who are infected when there's an infected member of a household, which is obviously close confinement as well too, It's about 15%. Now, what does that mean? Well, that's typical of influenza, and it's typical of a lot of our respiratory viruses that spread by respiratory droplet. It's not typical of measles or varicella, where you have much more significant transmission, and the secondary attack rate is nearly universal in those households. So, nothing's ever binary in our world. Like, there is no yes or no. And I'm not surprised that in certain circumstances, a really dingy bar with like, no circulating air, that there could be aerosolization that occurs in the right, winter climate or cold environment. And then you suddenly have rapid spread. Sure, that can happen. But by and far, that's not what's happening. And so you need to think, I would not overthink the ventilation issue beyond making sure you have acceptable ventilation. We have, I think, at Children's Hospital of Philadelphia, 6 exchanges an hour. I've learned more about, but I'm not a ventilation expert, so I don't want to claim. And many of the schools have worked to ensure that they have very similar levels of hospital quality air. And if our physicians can work in those kinds of exchanges, I suspect our teachers can as well too. There are some additional layering for those places that didn't have the opportunity to upgrade the air exchanges. I'm not knowledgeable on the efficacy of the floor purifiers, but I actually think the value add in terms of these mitigation strategies is clearly weighted towards physical distancing and masking, and then the hand hygiene and keeping sick kids out of school. And you do the ventilation if you can. But don't overthink the contribution to that ventilation unless you're really in an older building that is not providing sufficient sort of what everyone would agree to is basic levels of ventilation within the schools.
I think the only other thing that I would add is, again, I'm not a ventilation expert, but in our sort of review of the evidence from the folks who are doing this research is that, even very simple things like a window cracked 4 to 6 inches significantly improves the circulation in the air. So to the extent that that is possible, and again, in buildings where the HVAC system is maybe not doing 6 exchanges, at least 6 exchanges per hour, whatever it may be, I think there are things that do work really well, like very minor things like making sure that the settings are set to not recirculate indoor air, but to be pulling air constantly from the outdoors. So I think these are things that schools can do in consultation with their HVAC sort of consultants and providers or environmental services, whoever is responsible. But as Dr. Rubin said, keeping it very simple, knowing again that this is not the predominant way that the virus is spread, and that there are very simple ways to improve air quality that don't require renovating an HVAC system.
Thank you. Another theme in our questions relates to the transmission of the virus on surfaces. Specifically, what's the risk of contracting COVID-19 from a surface that a student has touched or shared, like a desk, maybe student cubbies, science lab equipment, or even things like paper supplies or library books? Is there a time that those things should sit dormant before they're used by the next group of students, or what are the protocols around that?
We've had a lot of discussion about foam, what's called fomite transmission, which is getting infected from touching an object and then touching your face or touching your eyes. I will say for the teachers out there, one of the things that I'm recommending is if you do wear glasses or you want to wear goggles, it's not just the mask, but there is value of wearing those goggles in terms of touching your eyes. There was even a study I saw earlier from overseas that suggested that they were seeing fewer patients with eyeglasses in the hospital, sort of consistent with the hypothesis that the glasses do protect you to some degree as well too. But the reality is, with regards to fomite, and even the CDC has said this, and it was controversial when they discussed this. But before the CDC became politicized over the last couple of months, they had actually said that the risk of fomite transmission is extremely low. Like when you get your mail at home, you don't need to, you can open your mail. that they weren't seeing significant transmission off these surfaces. That said, when kids are coughing in the class, and they cough on a desk, the reason why we do the hygiene and disinfection is because there could be viable virus that lives on those surfaces. But I would suggest regular and maybe increased hygiene and disinfection of the classrooms. But beyond that, I would just make sure the kids are using hand sanitizer. I think that's probably what I would do, but I wouldn't want to overdo it where you're constantly wiping things down all the time. Dr. Matone, you have anything to add to that?
No, I would agree with that. I think if there are objects that are going to be shared by multiple cohorts of students throughout the day, technology, desks, what have you, that increasing the number of times that those are wiped down. But I don't think that there need to be protocols to sort of let things sit for 3 days, if a student has touched it. I think if we're able to have the students doing regular hand hygiene, if masks are on, that sort of reduces the likelihood that kids are going to be spreading things right to their nose and mouth. And so I would agree the risk of fomite transmission is on the lower side. I do want to acknowledge, though, that it's probably higher in a school environment than in other community settings, just given the hygiene practices and the face touching of children. But I think, again, not something to go crazy over, as long as they're sort of sensible. If 6 kids have touched this, maybe I'll give it a wipe down before I give it to the next child. That type of thing, rather than sort of standard protocols of keeping track of how long we've quarantined a particular object. I don't think we need to do that.
Thank you. Some of our participants have questions related to programs like music. The questions are related to, what's the safe distance between performers? And is there any time when students are indoors that they could unmask and sing?
Well, we're going to enrich some of our recommendations soon. So stay tuned. We're doing a revision of our guidance, and we're going to focus a little bit more on music. And we've been in touch with a couple people of really interested and thoughtful people out there who have reached out to us on that. Clearly, singing and even the use of wind instruments in the band are considered significant potential risk. I don't think the data is great in either way in terms of how much additional conferred risk. There are studies now going on around the country that are very early to try to understand the nature of the risk, but we've seen very significant outbreaks through choir practice throughout the country. Those have been well established in indoor environments. So I see a lot of music programs moving kids outside, recognizing that's going to, again, you're layering on new strategies. So you're moving kids outside. I see people spacing folks out. We talked about 20 feet. I think that probably was extremely conservative. In the presence of masks, we just don't know in the presence of masks how much you can, make that shorter. But, because the risks of outbreaks have been so high and the amount of virus expelled much higher among the singers, it's important to consider, and I would want to keep kids fairly far apart in indoor. And I don't think we're at a level of transmission now that we can remove the masks. If you're standing 15 feet apart outside, I think that is an opportunity that you could do that, and I think that's fine. I think we're going to do smaller quartets this year. There are some new there are bell covers that people have been using for some of the instruments. I still think the jury's out on how much those are protecting against virus being transmitted, and certainly suspending droplets in the air. But certainly your wind instruments in particular need to be spaced out a lot more. I think you can use your regular 6 feet and your regular distancing, everyone wearing masks for the rest of your instruments in the band. But I think you're just going to have to adopt new routines where you're either practicing outside or working in smaller groups this year.
I think the only other thing I would add is duration. We know duration matters. And so if there was, in the past, a 2-hour choir practice, I might suggest shortening that, particularly if it's indoors. So I think that that's another sort of component that folks have been talking about when we think about sort of the the spacing, the masking, and the duration when we're thinking about music programs.
If we had all the testing we could have, I mean, Hollywood is going, and they're and theater is going, but they're back, but they're using frequent surveillance testing to try to minimize the likelihood that a positive individual is introduced, much like the NFL. I would think of music to be very much like football. It's a high, it's a high exposure likelihood, and you just have to think about either ways to mitigate the risk and how you do it, or eliminate the risk through really strong compacts. If it's a small a cappella group and they're very much, they have a strong quarantine, these are the judgment calls you need to make because you don't know the circles outside of their life at school. But I think the risk for transmission would be extremely high if you get a little bit if you get a little bit too loose and fast with the protocols, particularly in those settings.
Okay. We also have some questions and concerns related to our food programs and cafeterias. Specifically, what's the recommended distance that students should maintain while they are unmasked and eating? And what protocols are safest for those adults who are in the room for supervision during that time when students are unmasked?
I would suggest that adults and sort of monitors, lunchroom monitors, be masked and maybe choose a separate time to eat when they're monitoring cafeteria time. And I also think that when we think about sort of what are the activities that present the most risk during a typical school day, that sort of shared meal environments and lunchtime is probably at the top of that list. And so from our perspective, sort of depopulating lunchrooms as much as possible is going to be sort of a very high value intervention. And I would say that this is a time where at least 6 feet of distancing at least is useful. And as much as it's a bummer for everybody, especially the students, I think thinking about classrooms or sort of smaller lunch cohorts is staggering meal times. These types of things to really depopulate cafeterias are going to be a very high value intervention.
Yeah, and I'll just add, a lot of the schools that I've been speaking with are doing like quieter lunch times in the classrooms with box lunches if they can, but they're also doing quietly. The kids aren't talking, and they're not sharing food and drinks. I mean, that's really the big risk. So some places are putting on audible books, they're putting on documentaries to try to encourage more of a quiet approach to lunchtime, and so there have been some creative strategies out there to reduce the amount of risk.
The vast majority of our questions somehow relate to masking and questions related to that. So I'm going to try to break them into groups so that we can have sort of more digestible responses. The first is, can you weigh in on the mask versus shields versus plexiglass conversation? Specifically, which of those mitigation efforts is worth pursuing? What would you recommend?
We would recommend masks, if it's a masks or shields or plexiglass, hands down masks win. I think the evidence is very compelling. Shields are helpful, particularly for eye protection as an added layer of protection with a mask, but a shield still allows sort of virus particles to escape. I think the situations where we have children with learning differences or children with medical complexity that are going to have a difficult time with a teacher who is masked because they're not able to pick up on those visual cues. I think there may be situations where a shield is used without a mask. In those circumstances, we would suggest having at least 6 foot of distance and having that time, to the extent that that possible, that unmasked face shield time be minimized, and that in situations where teachers are working with students who they themselves are not able to be masked, that teachers might consider both mask and a shield for those interactions.
Dr. Matone, can I follow up with on masks? Can you talk about recommendations as to what type of mask? Because you talk about gaiters and single layer, all kinds of different masks out there. Can you talk about that for a little bit, please?
Sure. So we are not recommending, because they're not as efficacious, certainly not for teachers and not for students either, bandanas or gaiters. I think masks are what we are recommending. Cloth masks are appropriate. Outside of medical settings, N95 masks are not what is being recommended. There's not really evidence to suggest that outside of medical settings that N95 masks are needed. So I think cloth masks, that are double layer, and there are a lot of mask options now that sort of have an extra pocket for an extra filter. There's a lot of really nice and affordable cloth masks out there, and we are recommending that those are efficacious and get the job done. They should be washed on a daily basis, or if they are sort of soiled during the day, that teachers have sort of a backup that they can change to, but at a minimum, washed with warm soapy water on a daily basis. You don't want to be reusing a mask day after day. Surgical masks, which can be purchased off of Amazon, are also appropriate. Those, if surgical masks are bought, and those are like the light blue ones that you've seen folks wear, that's a surgical mask, and those are disposable, so they should not be worn for more than one day at a time before disposing of them, which is why many folks are opting towards the cloth masks. So totally fine to use those. They get the job done. The thing that you want to make sure is that nose and mouth are covered completely, and that there's not big gaps. So really, more than the material of the mask is how well does the mask fit. The more sort of gapping here, the less efficacious the mask is. And so to find something that fits well, is comfortable, that you can keep on, because that's really the main goal.
Some of the questions revolve around mask breaks and how to safely and effectively take them during the day. Specifically, is there a safe way for students to take a mask break at school without going outside? And if students take a mask break in the classroom, what risk does that pose to the other people in that space?
So we're recommending that teachers that wish to institute mask breaks, that first, from what we've seen, if it gives you confidence from the schools in our area and across the country that have reopened, students are tolerating masking very well, and in many ways tolerate it better than we as adults do. They just go with the flow, and if this is the new norm, this is the new norm. And so I think we've created a lot of anxiety around this narrative of students that really we haven't seen play out by and large. It's going really, really well. That said, I do think there are times when, you as a teacher might sense, the kids could just use a break right now, or you're just going to build it in as part of your day. In that situation, what we're recommending is that everyone be distanced, seated, that it be a part of a quiet time where children are at their desk, distanced, and that the break be less than 15 minutes. If that is all sort of followed, then we're thinking that this is going to pose minimal risk to everyone in the room, including the teacher. I would say, teacher, if you keep your mask on during the mask break, that would definitely be a recommendation. But I think we probably don't need too many of these throughout the day, because students are going to unmask when they drink water. They're going to unmask during their snack or lunch times. And so we already have sort of those built-in times where the masks are going to be off. And so if another mask break is warranted, or to make sure that it is during a quiet time, students are seated, they're distanced, and that the duration is less than 15 minutes. And to the extent possible, that everyone is practicing hand hygiene before and after they are touching their mask.
Okay. And one last mask question, and then we'll move on to a different topic. And that is, if teachers are alone and teaching in a room, or if they're in a space alone, do they need to be wearing a mask because of the shared ventilation?
I would say no. We don't wear, we can sit in our offices, we take our mask off. Yeah, again, that's, with the aerosolization question, even in our pediatric offices, we haven't had any transmission at CHOP. I didn't mention that, there was a lot of anxiety, and I think this is an important moment to say this. There was a lot of anxiety when we first went back to work at CHOP in March and April when things were soaring. Nurses, office staff, everyone was afraid until we instituted these protocols, and we haven't seen transmission occurring in the context of the hospital. We've certainly seen staff who've been positive. The few times we've seen it, and this gets to your lunchroom conversation, is when teachers kind of hang out with each other in the break room and have a cup of coffee and they remove the mask. I think of everything as the moments of transmission, and so that's an extremely high risk moment. So we should thinking about how teachers are going to, where they're going to grade their papers, where are they going to sit down. I know it's you have really important friendships with folks, but we let down our guard the most with the people we trust. And I've even spoken to the task force and leaders of the coronavirus task force who have said the greatest risk we have throughout the rest of this year is going to be family gatherings. And so it's friend and family gatherings. And so it's just a reminder that to the staff that probably the greatest risk to you is what happens in your break room, and not from the students in your classroom. And then, in terms of being alone in your office, though, I think that is a safe moment to remove your mask and take a break. And we do so at CHOP, and we haven't had transmission.
I'm going to shift the direction a little bit to a different topic, and that is related to athletics. Specifically, can you speak a little bit about indoor sports and the things that we maybe need to keep in mind related to that?
Well, we're trying to get through outdoor sports season right now, so maybe I should start there, Jennifer. Right? So are you guys playing football or not playing football? Playing football.
Yes, we are.
Flying blind and playing football, right? Some new data on football, actually. So the first thing I want to tell you, is, there's been some interesting developments in the football space. I mean, obviously football has been one of our most concerning sports because we've seen outbreaks in college teams that are testing every day. We're seeing outbreaks in the NFL where they're testing every single day, all right? And so it's very concerning that we're restarting high school football. But that said, high school football is part of the architecture of our schools, and it has been, for a long time. And I'm sort of more of a pragmatist from that perspective. Is can we learn some things about where transmission is occurring, and make modifications like we would elsewhere? It's I do think it confers a lot of risk, but if you're playing football, what my understanding is, based on the outbreaks that that we've seen around the country, is most of the transmission is not occurring out on the field. It's occurring, football players also like to be the ones who have those parties on Saturday night, right? And so to me, there's compacts within the team. There's coaches being knowledgeable about the activities of their athletes if they want to play football, because I can already tell you a lot of teams have been quarantined already because of knucklehead behavior of the kids who decide that it's okay to go out and party and have a great time, but then they want their football even while they're positive. Well, they're not getting their football if the whole team's positive. But the good news is it doesn't seem to be happening on the field. And when the Tennessee Titans played the Minnesota Vikings this past week, I don't know if people noticed that the Titans got shut down, but they played the Vikings, and several of those players were positive during that game. There wasn't transmission between the Titans and the Vikings that I know of at this point. We're still trying to track down the South Bend outbreak on the Notre Dame team, which happened during a pregame meal. So pregame meetings and meals those are really critical moments indoor. If the coaches are letting players take their masks off or sit in close proximity to each other, they're blowing it. And then the biggest risk for transmission is that dingy locker room where kids are changing and they're showering. And so to me, if you're playing some of the, whatever sport you're playing, whether it's a high contact or high exposure sport, I would be focusing on and I've spoken to health department directors. I'd be eliminating the locker room transmission risk. That's something everyone can agree to. Shower at home, or space them out to get dressed and then have them shower at home. But minimize the chance that that's going to be the moment where it happens, because it doesn't seem like the highest risk moment is actually happening on the field. Now, when we get to basketball and we get to indoor high risk sports, my job in the next few weeks is to try to reach out and get some more contact tracing information from some of the professional leagues. And I think we're going to have more to come on that in our guidance as we learn a little bit more about what the NBA, for example, has observed and what college teams are starting to observe. Is it the same pattern that we are seeing? That's an indoor sport with really sustained close proximity work, even arguably more than even football. And so there's a lot of different elements in the basketball court. And so, do you need to do frequent testing on those kids? Is that going to be more important for basketball than it was in football? I still think we're trying to answer those questions. Wrestling is another one that's extremely challenging. Ice hockey has been extremely challenging, but has been very much, a greater worry around the locker rooms, is my understanding. And then certainly the meeting of students and the partying of students outside the hockey rink. I'm not sure the junior hockey leagues where they're not dressing in the locker rooms and they're going home have seen outbreaks in the same way. So there are ways to mitigate risk for all these sports that are trading practical realities like we've talked about by layering on other approaches that you can't necessarily replace. And that's a long answer to say you got to be creative and you got to figure out ways to minimize the likelihood of an outbreak originating and then hope for the best.
I'm going to shift us back into the classroom. I know we're getting close to our time, so we just have this and one more question. When we think about students and teachers together in a classroom, certainly a teacher moves around the classroom to deliver instruction. Is there any risk, or should I say, how do you mitigate risk for teachers who want to get within 6 feet of children while they're teaching?
Well, I do that in my office every day, right? So 15 minutes. Make those episodes brief. And if you do so, you should be okay. As everyone's masked, make sure the environment is safe. And you can get within 6 feet. You just got to make those interactions briefer, and then step away.
So the same advice would apply to people like school counselors or
Absolutely.
other professionals who meet in tighter spaces with kids.
Sure. And try to, if you can, eliminate those, if you have the ability, eliminate those tight spaces. If you're going to meet with them longer, go walk outside, take a walk down the street with them. Right.
Okay. If I can follow up on that one, Dr. Rubin, that you think about counselors, sometimes they're working with students who are emotional, they're crying, things are, do you have any guidance, additional guidance around that kind of a situation?
Well, again, 6 feet, 15 minutes, right? Sometimes you need to put your arm around a kid. It's okay. All right. And certainly, part of your multi-layered strategy was the kid wasn't symptomatic when they came to school that day, right? So the risk of transmission is going to be lower. You remember what I told you in the beginning, at 50 per 100,000, you're at 5 out of 1,000. At 100 per 100,000, which is a number we may get familiar with in a couple of weeks. That's still only 10 per 1,000. So even if you just pulled off the mask and hung out, and it's still a pretty good probability that that's not the individual if they're asymptomatic in the school. So when you add the concreteness to this, you want to do good. You don't want to. You want to protect yourself from getting this, but use your layered strategies. And don't see them as absolute. They work together in tandem, and they're not. Perfection is the enemy of good. And I think that if you embrace that, I think you'll kind of learn how to become familiar with this. I still put my arms around some of my patients and say hello to them, right? We're masked and in the office. I know they're there for a well visit. They're well. It's a brief interaction. I think, we have to feel comfortable accommodating that way. We can't just kind of all sort of distance from each other 100% of the time.
Last question, and then we'll wrap it up for tonight. And that is, we're sort of asking you to use your research and your knowledge, and to some extent, maybe a crystal ball, to look into the future. We've heard in the media and in some reports that some are anticipating a spike in southeastern Pennsylvania in the coming months. Is that what your research suggests?
Oh yeah. I mean, we're all going to see it, right? And even I can tell you, I've reviewed the models this week. You're going to see a spike in Philadelphia this week. Whether it's sustained, we'll have to see. The collar counties have seemed to held. New York is really beginning its own surge right now. I mean, we're definitely past the lowest numbers we're going to see for a while. But again, it comes back to these protocols. And what's different now from where we were in September is we now have contact tracing data, and we've got teams in our health departments, particularly in our collar counties, that are getting much more sophisticated in their way they're tracing these individual cases. And we have to rely on them more than ever, because the numbers are going to look scary. But really matters is, are these protocols protecting our schools? And the moment we see, and I will call it, the moment we see clear-cut evidence that we're starting to see increased transmission originating within the schools, is a time we might need to hit pause based on the case incidents in the areas. And so we're walking away from absolute thresholds and more towards the recognition that we have teams on the ground that are going to help us make this decision, because our goal is to fight like hell right now to preserve our schools and to continue them to have them be safe, even as there might be outbreaks occurring in the wider community at restaurants or bars or wherever these things are going to occur.
Well, we are at the end of our time this evening. I want to thank all of our participants for joining. A special thank you to you, Dr. Rubin and Matone, for lending your expertise and insight. We're grateful for the time that you've spent with us and the information that you've shared. As a reminder to staff, this meeting has been recorded, and information about how to access that recording will be shared with staff in both districts. Dr. Sandville and Goffredo, any closing remarks?
No, thank you, Jen, and Dr. Matone, Dr. Rubin, thanks so much. This was fantastic, and really just, I think the information is power, as I said earlier, and this was great. I really appreciate it.
Yeah, build your strength in your protocols. I'll tell you, it adds confidence. After a few weeks of doing that in my practice, I'll be seeing patients tomorrow. I started to feel safer at work than I did walking through the market. Right. And I think you'll understand that if you've been walking through the market over the last few weeks. People are getting a little loose and fast in terms of what they're doing. Right. And so when you start to see it in the school day and you start to build confidence, it actually makes you feel like I can be safer here. Like I can be okay here. I can do this. And I think that's what we hope for all of you, that we can keep these schools open as long as possible, stay safe, and just be practical about it. And I think we're going to figure out how to accommodate the best we can to the situation that we're in.
Dr. Matone, Dr. Rubin, thank you both so much. Again, I know I speak for John, myself, our whole teams. Thank you so much. It's so important that we keep our children safe, our staff safe, and the information that you gave here tonight is going to help us in terms of our preparedness. So thank you both. I know you do this a lot with a lot of the communities. You've been on calls with John and myself, and other superintendents. Thank you so much for your commitment to supporting all of our schools and all of our staff. Thank you so much.
Good luck, guys. All right.
Yeah, good luck.
Thank you, everyone.
Good
Stay
luck.
well.
Thank you.